So without too much of ado, I really want to just quickly introduce Alexander Hamilton, almost as famous as the Fabulous musical. Keen interest, research interest in psychological health and well-being in young adults, pretty famously leading the SPEAK study about 3 years ago, which was a bit of a landmark study for lots of us. So Alexander, if you don't mind.
Thank you.
The screen is yours.
Just checking everyone can hear me okay?
Sure, we can. Beautiful.
Good. I just had a bee fly into my room, so I managed to get it out just in time. So thanks, Arvin, for asking me to speak. And I'm going to talk, share some research findings about how young people experience peritoneal dialysis. And I think there's lots of pointers here as to how we could improve that experience for young people. So the first thing to say is, as children get older, the use of PD falls as it's replaced by transplantation. And if you look at registry data, most children on kidney replacement therapy who transition to adult services do so with a transplant. The vast minority do so on PD. So it's not something we see all that often. And if you look at how 11 to 30-year-olds are treated when they first start kidney replacement therapy, the most common treatment is hemodialysis in over half, which over the first few years gets replaced by transplantation. But 30% of incident young people start renal replacement therapy on PD, and this falls off and always remains the sort of least common modality. And turning to data from the SPEAK study, in this study, we looked at all the young adults who were reported to the registry in 2015. There were just over 3,000 16 to 30-year-olds, and only 5% of those were using PD at the time. So it's quite underused. So this prompted the research to investigate why that is. But what else do we know about young people on kidney replacement therapy? Well, we know that quality of life is reduced for all people. So for those on transplantation, it's not normal, but for those on dialysis, it's further reduced. And some of the reasons for that are shown in interview studies. So there are 5 minor themes experienced by people. So these are around body image, being able to join in, having isolation or intimacy issues, and then having problems with education or employment. And these come together under 3 major themes of being different and being aware of that and wanting to be more normal, and having to adjust your dreams and ambitions in the face of having kidney failure. The sort of key theme is living in limbo, never knowing what's around the corner from a health perspective. So I worked with Hannah Lyons, who's shown here, who's a medical student. She graduated now. And she was undertaking a health sciences master's at Bristol University, so I supervised her to do this work. So she started off with a literature review to find what factors are associated with failure of peritoneal dialysis amongst all patients. So she identified some protective factors, so being older, having higher education, or being employed, interestingly living further away from your treatment centre, and having a normative BMI were all protective factors. Whereas being male, being of Black ethnicity, being of lower socioeconomic status, being referred late, or having diabetes were risk factors for PD failure. But amongst these protective and risk factors, there was a number of psychosocial factors in the mix. So body image, which we've seen as a quality of life issue for young people, adherence, and 43% of people in SPEAK reported low medication adherence. Patient activation, which describes the knowledge, skills, and confidence to self-manage, something that's very important if you're on a home therapy. Support, which you will hear more in detail about during this talk, and acceptance of illness. So what Hannah did was something called a sequential explanatory mixed method study. And what this is a quantitative analysis where some qualitative interviews were undertaken with people to explain and understand the quantitative findings. So I won't go into the methods in detail, they're all here. The key things to highlight is that we define failing PD as an unplanned switch to hemodialysis. And then I just wanted to iterate that the quantitative methods are very rigorous. So you come up with a topic guide You undertake semi-structured interviews with people which are transcribed verbatim, then they're coded, and a coding framework is created which is applied across all the interviews, and then thematic analysis can be undertaken to pull out the key overarching themes. And the nice thing about this approach is it explores and explains your quantitative findings. So in the SPEAK study, there were 976 people, and we had data on timelines from the registry for 911 of those. And about half of these people had ever had PD. So this is something that applies, quite a wide range of people. And a quarter of those people had had PD more than once in their lifetime. At 3 years, 50% of people had failed on PD. So it wasn't a treatment that lasted for more than 3 years in the majority of people. We came up with a multivariable model to look at factors that were associated with failing PD. And what's really striking here is you see exactly the same pattern across young adult age ranges as you see with kidney transplant failure. So as people get into the 15 to 19 bracket, their risk increases, and it stays up there until past the age of 30. So we had data on the reasons that PD failed in about half the cases. And the most common cause was infection, followed by compliance issues and mechanical problems. So I'm going to spend a bit more time on the qualitative elements because, as we've heard, the quote's very powerful and very rich. So what we did was we approached people who'd been on PD most recently in the SPEAK study and asked them if we could interview them about their findings. So 17 people gave consent, and the data I'll show you is based on 11 interviews. So these were the major themes found in the data. So the first three, compromised autonomy, support structures, and life impacts, were particularly relevant for people who had experienced PD failure, whereas resilience was a theme seen just with people who had not experienced PD failure. So I'm going to explore these themes in more detail now. So each of these major themes is comprised of minor themes, and I've got some quotes to illustrate these. So the first minor theme of compromised autonomy was a lack of information. So people felt they only received information about PD, and the other alternatives weren't discussed. So this information was biased. Clinicians felt that people would do better on PD and so pushed it. And there was feedback about the way that information was delivered. So very text heavy, unpatient friendly pieces of paper, no sort of booklets with images, no success stories, and that's what people wanted to see. So altogether, people felt they lost their ability to make an informed choice. And we see this time and time again, but the benefits of peer support start to come through. So people felt it would have been really helpful to speak to someone else about their experiences, and critically to have some reassurances that things are going to be okay. But they also wanted the good, the bad, and the ugly. They wanted an honest appraisal of what things would be like. So moving on to the next theme, which was impact on life. People found PD difficult. It was intrusive. They couldn't escape the responsibilities of keeping their tube clean. Dealing with deliveries and stock taking was something that came up an awful lot in the interviews, but people found it intrusive and difficult. And they couldn't escape PD because the next exchange was always hanging over them, whereas they noted that when they were on satellite-based hemodialysis, they could have a day or two away from treatment and escape it. And people told us about stopping doing things that they enjoyed, like going to the beach or playing sport. And it led to bodily insecurity. So this person gave us a very frank quote about the fact that they felt grossed out about having a tube, and it put them off their sex life, which is a very important part of your life. People did think that PD gave them a bit more freedom so that they could dialyse when and where they wanted to, rather than being in a rigid thrice weekly satellite dialysis slot where they'd have to rearrange. So there were pros and cons. And then support structures. So a number of different support structures were identified. So the first was family. And this participant hadn't realised in retrospect how much her mum had helped her with stock taking and how much time she'd put into that. but it impacts people when they went away to university. So this person told us that they had disagreements with their 4 housemates, especially about how clean the bathroom was and where to put all the deliveries. And she felt that this was one of the reasons that she developed peritonitis. And for her, it would have been ideal to live on her own, but this had a financial impact, which wasn't possible. So it was really difficult. And again, we heard about peer support. So the emotional support of being able to just to talk to someone else about what you're going through and perhaps find, you know, potential solutions using that approach. And the health professionals were mentioned as well. So both the provider, Baxter, in this case, was felt to be very responsive and of practical help, but also the PD nurses were felt to be always there for you. They've got your back if something goes wrong. And then chiming with other things we've heard this morning, mental health support. And this person sort of telling us that it got progressively worse. They didn't know that help was available. And when they found the help, it was really useful. And someone else saying that they didn't realize that things were getting so bad. And this, again, chimes in about a disconnect between being aware of mental health problems and the detection of mental health tools. Someone I think needs to mute. I'll pass on. And resilience was a theme found in people who didn't experience PD failure. So this was comprised by having previous childhood illness. So this person had a long disease course that they were first ill when they were 5, transplanted at 9, and they knew that this kidney wouldn't last them forever. So they knew a return to dialysis was fairly inevitable, and that helped them deal with making that transition. And there was the sense of dialysing to live rather than living to dialyse. So people just wanted to dialyse to allow them to do the life participation activities that were important to them. So just to summarise, I've shown you that there's an increased risk of PD failure during young adulthood, and the leading causes of PD failure in this age group were predominantly infection, followed by compliance and mechanical problems. And the themes that people experience were a compromised autonomy, big impacts on their life, and awareness of multiple different support structures, and resilience being a protective factor. So it now seems that young adulthood is a high-risk period for all kidney replacement therapy, not just transplant. So there's a number of limitations to the study. It's retrospective. We had a lot of missing PD failure data. We only looked at surviving patients in this analysis, so there's a possibility of collider bias. These are based on experiences from a few years ago, so there's a possibility of recall bias. Normally for qualitative methods, you'd use purposive sampling, but we had a small sample size, so weren't able to do that. And then this took place during the pandemic, so it's uncertain how that impacted on the findings. Just turning to the wider literature, there's only one other study we could find which was similar, which was based on the experiences of young people on PD in Mexico. And it found some common themes around body image, but particularly around the material resources and the information that was provided to young people. And I think this is a key sort of low-hanging fruit that we could really improve upon. And when you look at the standardized outcomes for nephrology, core outcome sets, both for kids, which is children and young adults, and peritoneal dialysis, there's some common first tier outcomes, which are critically important to all stakeholder groups. So life participation. So I think it's a challenge for us to think, how can we provide renal replacement therapy to people that allows them to do the life participation activities they enjoy, and how can we keep people safe and free from infection? I think thinking outside the box is really important. So actually, hemodialysis can be good for you if you're a young person, as shown by Joyce Papula and colleagues in London, who cohorted young people onto a twilight dialysis shift. And with the input of a youth worker and having a monthly multidisciplinary meeting, showed great improvements in DNA rates down to 0, improved medication adherence scale scores, and improved dialysis quality indicators. So, you know, sometimes a hospital therapy is the right thing to think about. So this is the nice transition guidance infographic. And the key things here are having a named worker to support transition, early planning, but identifying support. So again, chiming with the support structures that we found. Something I find interesting here is the idea of a named worker that we refer back to if a young person doesn't engage with. In my experience with youth services, that simply doesn't happen. So what resources do we have? And this is by no means an exhaustive list, but for young people who are transitioning or young people who have presented directly, we have multidisciplinary clinics, and in terms of support,
488-218-4494. Okay,
if everyone could just, Umair, if you could make sure you're muted, please.
Guys, can you all mute?
So peer support, so we've got the fantastic Young Adult Kidney group. We've got Holly from the group here today. I checked this morning, there's 613 people signed up to that group. There are trained peer supporters. It's funded by Kidney Care UK. So that's a great resource. There's family. We often see family coming to clinic. I very rarely see friends coming to clinic, and that could be something to tap into. As we heard from Tanya's talk, the importance of embedded psychological support. Personally, I think we probably need to do more screening to identify low-level problems and try and be more proactive. And obviously, we have fantastic youth workers. For this talk, obviously, the role of the PD nurse is really important, and they could provide regular education or technique checks to try and keep people free from infection. For this age group, though, RRTs are a spectrum where over your life course, you might experience all the different modalities. And I think shared decision-making is really important to work out what's best for someone at their specific time of life. I think what the study is we really need some standardized, realistic, accessible information for young people. It needs to be co-produced. It needs to tackle sex and body image, how to manage dialysis when you go to university, and how to manage your workplace. And I think we've seen compliance come up a lot, and it could be useful to routinely assess this in our clinical practice. So I just want to acknowledge everybody on the slide, and that's all I have to say. Thank you.
Thank you, Alexander. Lovely talk as always, and a bit self-deprecating on the quality of the study. I thought that was an extremely rigorous methodology considering the sort of things that you were trying to capture. So a couple of themes. Slido, Jensen and myself had the same question really, is about APD versus CAPD and whether that had a big influence on quality of life and positivity.
Yeah, the short answer is we don't know, because we rely on how well that's captured and coded in registry data. You often have one entry for PD, and it doesn't necessarily differentiate between the type. What I didn't go into is to do the quantitative analysis. It requires the amount of data cleaning to convert people's timelines into the type of data I could analyze. So I probably would have made my head explode to try and incorporate that into it as well.
Without giving you a head exploding moment, another thought, of course, was whether something we see very much in the adult service is the crash lander scenario. And if you start on hemo, it's very difficult to move to PD. I can't remember whether you said you were able to split the incident population into start PD versus move from.
No, again, we didn't look at that.
Can do that, no. I don't think I've got any other final questions. I've got perhaps one thing I just thought myself is, which you've touched on, is one of the big differences perhaps with PD is peer support or perceived lack of peer support. I think many of us have done this cohorting of younger people in the hemo unit, but you know, it's rather hands-off, the home therapies. I just wonder if you've got any other ideas how we can improve peer support, because I think that would make a difference personally from my experience.
Well, something we had experience of putting together a program locally, and we essentially found it was difficult to run and maintain. And you know, my personal feeling is we should probably point people towards the national resources like the Young Adult Kidney Group, which has come on leaps and bounds in terms of ensuring succession and getting rigorous training in place and all that sort of thing. So I think, there's 613 people in that group. There's a wealth of experience in there, and the original peer supporters have been doing it for a long time, and I think have learned the right way of doing it. So tapping into something that's already there, perhaps rather than trying to maybe start a new program, could be something to consider.
Good advice, thank you. So thank you very much. So that concludes the session before lunch.